If you have never experienced an orgasm, could like a simple injection at a wellness clinic be the magic key to unlocking it? Because today we are talking about the heavily marketed and, well, heavily debated O-shot.
Yeah, which is just everywhere right now. I mean, it's dominating social media, wellness blogs, aesthetic clinic menus, you name it.
Right, it's completely inescapable. So today for this deep dive, we are taking a massive stack of sources to figure out if this procedure can genuinely, help you achieve your first orgasm.
And we have a really broad spectrum of data for this
We
one.
really do. We're looking at the foundational clinical pilot study from 2014 by Dr. Charles Runels, plus a brand new 2026 comparative pilot study by Barber and Eglez.
Which is fascinating, by the way.
Oh, absolutely. And we also have a comprehensive 2025 systematic review of these therapies by Ismail and colleagues. And then, kind of grounding it all, we've got clinical guidelines from the Women's Health Clinic and some very strict regulatory statements from bodies like NICE, BPS, and the FDA.
Yeah, so we're going from like early experimental enthusiasm all the way to some very sober reality checks from the actual governing bodies of medicine.
Exactly. So the mission for this deep dive is to just cut through the celebrity endorsements and the glossy marketing hype. We want to uncover the actual science of intimate injectables.
What the data definitively says they can actually do.
Right. And ultimately answer if they are the solution for someone who has never climaxed. But I mean, before we get into the data, I just have to say, it is absolutely wild to me that we have branded medical procedures for sexual function now.
Oh, I know.
Like, it feels like having a designer label for cellular biology. It's just bizarre.
Well, the aesthetic industry realized pretty recently that sexual wellness is a massive, largely untapped market.
A very lucrative one.
Highly lucrative. And branding a biological process creates this very specific kind of consumer expectation. It basically frames a medical intervention as a retail product.
Like a luxury item.
Yeah, like something you can just pull off a shelf
Yeah.
to fix what is honestly a deeply complex human experience.
Which brings us to the core of the issue. Is this a genuine medical breakthrough, or is it just, really clever retail marketing? So before we can judge if this branded injection delivers on its promises, we kind of have to look under the hood.
We do.
Like, what are you actually buying when you pay for an O-shot?
Okay, so to understand what you're buying, we have to look at the mechanics.
Right.
And these were laid out in that original 2014 pilot study by Runels and detailed again in the 2025 Ismail Systematic Review.
Right.
The core technology is PRP, which stands for platelet-rich plasma.
And just to clarify for everyone, this isn't some, synthetic chemical they're injecting into you. It's autologous.
All right,
Autologous, meaning it's actually drawn directly from your own body.
Exactly. The process starts with just a standard blood draw from your arm. Then that blood is placed into a centrifuge, which spins it at these incredibly high speeds to separate the red blood cells from the plasma.
Okay.
And the clinical goal here is to isolate what's called the Buffy coat.
The Buffy coat. That sounds, I don't know, it sounds kind of gross.
I know it's a weird term, but think of a bottle of oil and vinegar salad dressing, right? After it sits for a while, it separates into those distinct layers.
Right, yeah.
The Buffy coat is that very thin middle layer of plasma that contains an incredibly dense, highly concentrated amount of platelets.
Platelets being the cells in our blood that act as the first responders. Like when we get a cut, they rush to the site to help with clotting and healing.
Exactly. But before this concentrated platelet layer is injected back into you, it has to be activated.
Okay, how do they do that?
The clinic will usually add a tiny amount of calcium chloride. And this chemical activation is crucial because it triggers the platelets to degranulate.
Wait, degranulate?
Yeah.
Is that like a microscopic capsule breaking open and spilling its contents into the surrounding tissue?
That is exactly what it is. The
Okay.
platelet itself acts very much like a sealed capsule.
Oh.
When activated by the calcium chloride, the cell membrane physically breaks open, it degranulates, and dumps all of its internal healing agents.
Oh.
It releases this massive cascade of growth factors and cytokines into the fluid. Cytokines are simply the chemical messengers that tell your body's immune and healing systems to just get to work.
Okay, so they activate it. Then what?
Once activated, this really potent fluid is injected directly into the clitoris and the anterior vaginal wall. Specifically, they're targeting the area often associated with the Skene's glands.
Which is what the internet likes to call the G-spot.
Right, exactly.
I mean, ouch. Just ouch.
I know. But the 2014 protocol does specify using a very strong topical anesthetic compound.
Okay, thank goodness.
Yeah, it's left on for about 20 minutes to achieve complete or near complete analgesia before any needles are even involved.
All right, so they numb the area, draw your blood, spin it like salad dressing, activate the platelets so they break open, and then inject those chemical messengers back in.
That's the process.
So what is the actual biological theory behind why doing all of that would improve sexual function?
Well, the hypothesis is rooted in regenerative medicine. By concentrating these growth factors and placing them precisely where the sexual response originates, scientists believe it activates pluripotent stem cells that are already resting in your tissue.
To the cells, okay.
Right. And this theoretically triggers a chain reaction. First, neoangiogenesis, which is the formation of entirely new blood vessels to drastically improve blood flow.
Okay.
It also stimulates collagen synthesis to improve tissue elasticity. And crucially, it supposedly encourages new nerve growth in the vaginal mucosa, which theoretically enhances your physical sensitivity.
Let me just make sure I'm getting this. So instead of just patching a tire, this is more like aerating and fertilizing a dead lawn so entirely new, healthier grass grows.
That's a great way to put it.
You're not just adding a temporary fix.
Yeah.
You are fundamentally trying to change the quality of the tissue itself from the cellular level up.
Exactly. You are providing the biological fertilizer.
Right.
But we really have to contrast that with other heavily marketed procedures to understand the whole landscape here.
Right, because there's more than one shot out there.
Oh, absolutely.
Yeah.
The 2026 Barber and Agalou study does a phenomenal job of comparing the O shot to something called the G shot.
The G-shot, yeah, I have seen ads for that, and honestly, I always just assumed it was a different brand name for the exact same procedure.
Most people do, but they are completely different biological mechanisms. The G shot does not use your own blood at all. It uses cross-linked hyaluronic acid.
Hyaluronic acid. Wait, isn't that essentially the exact same type of dermal filler people get injected into their lips or cheeks to smooth out wrinkles?
It's the exact same cross-linked filler.
You're kidding!
No, really. Instead of trying to grow new tissue like the PRP does, hyaluronic acid just provides immediate volumetric enhancement. It physically plumps the tissue of the vaginal wall, creating a mechanical bulge.
So it's quite literally lip filler for your internal anatomy.
Basically, yes.
But how does a physical bulge translate to better sexual function?
It relies entirely on friction. By narrowing the vaginal canal with a physical bump, it increases the friction and mechanical stimulation during penetration.
Ah, okay. That makes sense mechanically.
Right. But PRP, on the other hand, is a thin liquid. It doesn't create a lasting physical bump. It flows into the tissue and relies on that long-term cellular regeneration we talked about.
Oh.
So it's mechanical plumping versus biological regeneration.
That is a massive distinction for a consumer to understand.
Huge.
So if PRP is the fertilizer designed to grow new cellular grass, we need to see if it actually worked in the clinical trials. Like, did Dr. Runel's patients actually experience this miracle regeneration?
Well, we have to look closely at that foundational 2014 pilot study. It's important to note, it was an incredibly small study.
How small?
Only 11 women.
Wait, 11?
Yeah, ranging in age from 24 to 64.
11 women is a tiny sample size to launch an entire global aesthetic industry.
It really is. They presented with various forms of female sexual dysfunction, including anorgasmia and dyspareunia, which is severe pain during intercourse.
Okay, but what did the data actually say?
The data they published was undeniably eye-catching, which kind of explains the subsequent boom. They used two standardized questionnaires to measure the results.
Right.
The first was the Female Sexual Function Index, or FSFI, which asks patients to rate their levels of desire, arousal, lubrication, orgasm, and pain. The second was the Female Sexual Distress Scale.
Okay, so function and distress.
Right, and the study found that 64% of the women showed some degree of improvement on their FSFI scores. Furthermore, their mean distress scores dropped significantly, going from a score of 17 down to 7.
Okay, let's contextualize that distress score for a second. A score over 11 indicates clinical diagnosable sexual distress.
Exactly.
So dropping to a 7 means the average patient technically moved from clinically distressed to not distressed.
That's which is huge.
That sounds like a massive life-altering win. But here is where it gets incredibly fascinating. There is a detail in this 2014 study about side effects that you almost never see in medical literature.
Oh, you mean the extreme side effects?
Yes. The researchers noted what they called extreme side effects in 2 of the younger patients.
Right.
Like, the study literally reports that these 2 women experienced, quote, extreme sexual arousal. And it doesn't just mean a high sex drive. It specifically lists continuous sexual arousal, spontaneous orgasms, and even ejaculatory orgasms.
Those are the specific outcomes reported, yeah, for
Hmm.
those two individuals.
I mean, if an injection triggers spontaneous orgasms, that sounds like the ultimate cure. If it works that intensely, why wouldn't every single person struggling with sexual function be prescribed this immediately?
Well, we had to look at the why behind that extreme reaction and, more importantly, the timeline. The researchers themselves provided a really vital reality check here.
Okay.
Those extreme effects were completely temporary. They only lasted 1 to 2 weeks following the injection.
Just a week or two. But wait, that completely contradicts the theory of permanent nerve and tissue regeneration. You don't grow new nerves in 48 hours and then lose them.
Exactly. And the researchers hypothesized that this reaction had absolutely nothing to do with new nerve growth or cellular regeneration.
What was it then?
It was a temporary volumetric effect. When you inject 5 milliliters of fluid directly into the highly sensitive periurethral area, it creates continuous physical pressure.
But how does internal pressure mimic arousal?
So the Skene's glands and the internal network of the clitoris are completely packed with stretch receptors. They respond to physical expansion.
Oh, I see.
Yeah, so the sudden influx of 5 milliliters of fluid physically stretched those internal structures. That constantly fired those stretch receptors and essentially tricked the nervous system into feeling continuous arousal.
That is wild.
And once the fluid was naturally absorbed and processed by the body over the next 2 weeks, the pressure vanished and the spontaneous orgasm stopped completely.
So it was basically a physical parlor trick on the nervous system, not a permanent rewiring at all.
Pretty much.
And when we zoom out from those 11 women to the broader evidence, the picture gets, well, much more complicated. The 2025 systematic review by Ismail and colleagues looked at 17 different studies on PRP for sexual dysfunction.
Right, a much larger pool of data.
And the primary finding was massive industry-wide inconsistency.
Because there are virtually no standardized protocols.
Mm.
I mean, some clinics are injecting 2 milliliters of PRP, while some are injecting up to 10 milliliters. But the biggest issue Ismail found was the centrifugation.
The salad dressing spinner.
Exactly. If a clinic spins the blood too fast or for too long, the G-forces literally crush and destroy the platelets. You end up injecting useless cellular debris.
Yikes.
And if they spin it too slowly, they don't properly separate the plasma, then they are essentially just injecting regular unconcentrated blood back into the patient.
So it does nothing.
Right. And because clinics don't have to report their specific platelet concentrations, the broader medical community cannot endorse the therapy. We literally don't know what dose of medicine most patients are actually receiving.
And that perfectly brings us to the brand new 2026 Barber study, the one comparing the regenerative O shot to the plumping G shot.
Yeah, that study compared PRP directly against the hyaluronic acid filler. And surprisingly, at the 3-month mark, the temporary hyaluronic acid filler actually outperformed the PRP in improving total sexual function scores.
Wait, the filler beat the stem cell therapy.
It did. The hyaluronic acid group saw a 68.1% improvement compared to only 45.7% for the PRP group.
Okay, actually that makes perfect sense based on what we just discussed. Because the simple plumping filler beat the complex stem cell therapy since the hyaluronic acid creates that immediate, guaranteed mechanical friction bump. Whereas the PRP takes months to supposedly grow new tissue, and that's only if the platelets weren't crushed in the centrifuge to begin with.
Exactly. The data suggests that for many women experiencing benefits, the improvement might primarily be due to physical, mechanical enhancement and increased friction, rather than the promised cellular regeneration.
Okay, so we established that these shots can improve blood flow, they can provide mechanical stimulation through physical pressure, and they do raise scores on sexual function indexes for many women.
They absolutely can.
But we really have to apply this directly to the core question of today's deep dive. Let's think about the listener out there who is frustrated, who feels isolated, and who is seeing these glossy ads on Instagram promising a miracle.
Right.
Will the O-shot work if you have literally never had an orgasm?
So to answer that, we draw directly from the clinical guidelines provided by the Women's Health Clinic.
Yeah.
And their verdict is unequivocal.
What do they say?
The idea that an O-shot, or frankly any injectable, will give you an orgasm if you have never had one, is a complete myth.
A complete myth. Wow, let's break down why, because if primary anorgasmia means you have never climaxed, that implies the neurological wiring was never established in the first place, right?
Primary anorgasmia means exactly that. The root cause is almost always neurological, psychological, or relational. It is incredibly rarely a structural defect in the tissue of the clitoris or the vagina. Secondary anorgasmia, on the other hand, means you used to be able to climax, but a physical change occurred that broke a previously working system,
Like what kind of change?
perhaps due to menopause causing tissue atrophy or nerve damage from childbirth.
Okay, so it sounds like putting premium racing fuel into a car.
Yes.
If you have a functioning engine, putting premium fuel in might make it run smoother, faster, and better. But if the car's engine hasn't been completely wired to start yet, pouring premium fuel into the tank isn't going to magically turn the ignition.
That is the perfect analogy. You can't regenerate something that was never generated.
Exactly.
These regenerative treatments are fundamentally designed to restore lost function. If you have severe vaginal dryness from menopause or tough scar tissue from an episiotomy, PRP might genuinely help regenerate that damaged tissue and restore your baseline.
Right, it fixes damage.
But, as the clinical guidance explicitly warns, these treatments rarely, if ever, create entirely new function where none existed before.
Restoring a lost baseline versus creating a brand new reflex? That is such a vital distinction that the marketing brochures just completely ignore.
They leave it out entirely.
It's really heartbreaking to think of someone dropping $1,000 on a procedure, enduring the physical discomfort, only to realize the magic key was never designed to fit their specific lock.
And this is exactly why we are seeing heavy regulatory warnings coming down right now. The FDA in the U.S. and the British Association of Aesthetic Plastic Surgeons, which is APXN in the U.K., have both issued very strict public warnings.
They are not happy about this.
Not at all. They caution that the marketing hyperbole of the, quote, intimate aesthetics industry is vastly outpacing the actual peer-reviewed science.
The BAPS statement was particularly pointed. They called out the fact that non-specialist practitioners like people running cosmetic spas are buying these centrifuges and injecting people based purely on the glossy brochures provided by the manufacturers.
Yeah, they aren't reading the Ismail review. They are reading a sales pitch. And the UK's National Institute for Health and Care Excellence, NICE, which really sets the gold standard for medical care, has issued specific guidelines under IPG 6 and IPG 697.
What do those say?
They explicitly state that energy devices and regenerative injections are not first-line treatments for sexual dysfunction. They categorize them as emerging therapies. NICE dictates that they should only be used under special clinical governance.
Special clinical governance, what does that actually mean for a patient?
It means these procedures require heavily monitored clinical audits, usually within a formal research setting where outcomes and adverse events are rigorously tracked.
Okay.
It means they should not be casually administered in a strip mall medical spa, and certainly not until all standard proven treatments have failed.
All right, so if a listener is struggling and they are hearing that they shouldn't just jump straight to a $1,000 branded injection, what is the actual evidence-based step one?
Well, the evidence-based alternatives are much less flashy, and they definitely don't have celebrity endorsements, but they have decades of solid data behind them.
Which is what actually matters.
Exactly. If the issue is secondary, meaning physical changes like dryness, pain, or atrophy, the true first-line defense is topical vaginal estrogen.
Just estrogen.
Yeah, it is the absolute gold standard for restoring cellular tissue health safely. Hyaluronic acid moisturizers, and I mean used regularly as a tissue conditioner, not just as a lubricant during intimacy, are also highly effective.
Okay, but what if the tissue is healthy, but there's a lack of sensation or pain from past trauma? You mentioned an episiotomy earlier.
Right, an episiotomy is a surgical cut made at the opening of the vagina during childbirth, which can leave behind very tough, inelastic scar tissue.
Ouch.
Yeah. In cases like that or where there is deep pelvic pain, the gold standard is pelvic floor physiotherapy.
Oh, physical therapy.
Yes. A specialized physical therapist works on the actual musculoskeletal structure. They manually address muscle tightness, they break down that tough scar tissue, and relieve the involuntary nerve guarding that deeply affects sensation and comfort.
Okay, but what about our listener with primary anorgasmia? The person whose physical hardware is totally fine, but the neurological system just won't start.
That is where psychosexual therapy is the absolute first-line treatment. And to give that some vital context, the Royal College of Obstetricians and Gynecologists, the RCOG, notes in their training materials that roughly 20% of patients referred to gynecology outpatient clinics present with psychosexual dysfunction.
Wait, 20%.
20%.
That's literally 1 in 5 women sitting in the waiting room. If you are listening and you feel isolated by this, please realize how incredibly common it is.
It is so common. Psychosexual therapy uses cognitive, behavioral, and mindfulness approaches to address the complex psychological, relational, and neurological factors that govern the orgasm reflex.
So it's training the brain.
Exactly. It works to remove the intense performance anxiety and the subconscious mental blocks that prevent the nervous system from letting go. And orgasm isn't just a friction formula, It's a profound neurological release.
Which perfectly brings us to the summary of our deep dive today. I mean, the O-shot and PRP therapies represent genuinely fascinating regenerative science. The idea that we can harness our own blood to stimulate healing is incredible.
It really is.
And the data clearly shows it can genuinely help some women restore lost physical function, improve lubrication, and reduce pain from atrophy or scarring.
But they are not approved by the FDA or NICE as first-line treatments for a very good reason.
Yeah.
They are expensive, the preparation methods are wildly unstandardized, and the marketing often makes these sweeping promises the underlying biology simply cannot keep.
Most importantly for our focus today, an injection absolutely cannot bypass the neurological and psychological realities of experiencing an orgasm for the very first time. You cannot inject a reflex that your nervous system hasn't learned yet.
No, you can't. It requires patience, exploration, and often professional psychosexual guidance to build those neurological pathways. It doesn't just require a needle.
Which leaves us with a final thought for you to ponder. As the medical aesthetics industry continues to invent heavily branded, highly expensive physical fixes for our bodies, are we inadvertently ignoring the fact that our most powerful sexual organ has always been and will always be the brain?
It is infinitely easier to sell a quick physical fix in a syringe than it is to address the complex, invisible neurological reality of human sexuality.
It really is. So until somebody figures out how to put that in a centrifuge, maybe we should realize that we aren't fundamentally broken. We've just been looking for the solution in the wrong part of the body.